talk a little bit about the syllabus and how the course is set up, and I'll just kind of minimize this for a moment, real briefly go over our syllabus. The textbook is very, very helpful. If you haven't purchased it, my suggestion would be to do purchase it. It is worth it. It is a very good text, and your lectures essentially will be driven from the textbook. So kinesiology of the musculoskeletal system, the second edition. You can find them on Amazon, fairly inexpensive, or our bookstore. We do have the dreaded word exam. There are only 3 of them, and they are fairly equally weighted. We will talk more about that when we get there. I will we'll do reviews before the exam. I want to make sure you're well prepared before we have any of that. On occasion, if we need to alter when we take an exam, we can do that as well. So, but we do have 3 exams in this course. Very, very little homework, so to say, other than reading and preparing for class. So there's not a lot of work that I'll have you do outside of the class, other than preparing and engaging in conversation. As you can see from our schedule of lectures, labs typically will take place on Tuesdays. When we are doing a laboratory activity, usually something that will be conducive for movement. So all I mean in that situation is if we're doing a hip lab, your pants have to be stretchable enough for you to be able to move, not so tight that you can't get your legs up. When we do a knee, the same, flexible enough to be able to, or if you wear a pair of shorts, fine. When we talk about foot and ankle, you'll have to eventually take off your shoes. And gait lab, same thing. Skeletal, we'll be looking at lumbar mobility, cervical, primarily lumbar. Shoulder is probably one of my favorite classes and topics to discuss. There's quite a bit of information on the shoulder that we'll cover. So the class will move very, very quickly and quickly through. But the most important things and the most feedback that I've gotten from students in the past is what you look forward to is really the hands-on and the laboratory exercises. And these are direct applicable activities that you can take from here and apply into future patients. So on all the feedback that I've gotten, they all have enjoyed this class, and they have remarked that the laboratory was probably the most helpful for them. So I will attempt to give as much lab time and hands-on instruction time as possible for you, and show examples. And we can even, if you have a little problem with a joint, maybe we can help you out as well, get you feeling better. Okay. If there are any questions about the syllabus, feel free to ask. There is a couple little things. Food, drink, fine, don't worry about it. You can bring in Starbucks, caffeine, tea, no problem. There is no recording of the lectures. All the lectures are available on Blackboard for you to have. There's just no physical recording of our lectures or either video or audio recording of the lectures. And that's about it. So it's pretty straightforward. And once again, the textbook is probably important to get over the next few days. So let's start. Let's see where we're at. Okay. Kinesiology, as one of you may have mentioned, that you want to improve your understanding of human motion, and that's essentially what kinesiology is. And it truly is the influence of taking into consideration our anatomy, how we're built, how we're designed, the biomechanics, and the physiology. And it is a kind of an orchestration of all those into movement. So we will talk about those. Kinematics is a branch of kinesiology. So kinematics is the study of a body of motion, or the motion of a body, without regards to the forces acting on that. So essentially, we're just specifically talking about motion, but we're not talking about the forces involved. Okay? It's a study of movement. Body we'll refer to as an entire segment, or just one single segment of the body. So we'll use that term interchangeably. So if we're talking about the knee itself, we may ask, that may be referred to as the body of motion of the knee, or we may ask, or body may refer to an entire movement sequence of the human body. So I will do my best to break that information down so that there's no confusion. Sometimes terminology, to me, that just comes right out of my mouth and it sounds normal to me will have a different meaning to you. So if something sounds terribly off, and I'll give you an example. Last year I used the word courses, and course could be you're here at a course, kinesiology. Courses could also mean travel through. So we will refer to nerve. A nerve courses through the anterior aspect of the forearm and arm into the anterior aspect of the wrist and into the hand. So it also could mean travels. And I use that word courses multiple times in my lecture, and I got some strange responses that there was a little miscommunication. So I never want my, obviously, my lectures or my communication to interfere with that learning experience. Raise your hand. This is all about going back and forth. I want you to get the most out of this experience as possible. I want you to learn as much as you can to go home and help your fellow patients. Okay. There are two types of motion: translation and rotation. Translation can be broken further down into two other types. Straight line translation, so you have one surface or one joint moving parallel on another. So translation of the knee would be the tibia sliding forward on the femur. That would be considered anterior translation. Okay. So straight line translation is linear motion where parts move parallel to each other throughout the body. Another example is simply a special test that we do in orthopedics for ankle instability, and this is called an anterior drawer test. Okay. So I'm translating the talus or the talus on the distal tibia and fibula. When I'm checking stability of a knee, I'm checking the anterior translation of the tibia on the femur. Okay. Those are examples of straight line translation, which is a linear motion. Another type of translation is called curvilinear. So it's an undulating motion that occurs both upward and downward. And that essentially would be similar to our gait cycle. Normal gait cycle would have a curvilinear translation, where there's peaks and valleys of motion. So essentially, there's a vertical displacement of the center of mass. So our center of mass will travel upward and down. It could also be on a merry-go-round, where you're up and down as well. So it happens to be my two little ones enjoying what I call curvilinear translation, what they call just having fun. The other type of motion that we'll talk about is rotation. And essentially rotation is motion along a path about a pivot. In our situation, it would be a joint. Okay? So there's motion about a joint or a pivot, also called an axis of rotation. So rotation of motion occurs about an axis, and essentially the axis, there's no rotation occurring specifically at the axis. So it is the forearm, radial ulnar joint, moving about the proximal humerus. We'll talk a little bit more about this. We know that motion or movement is either active or passive. Active would be a muscular contraction. Passive would be an outside source creating that rotatory motion. Okay, something other than a muscle activation. And again, a very easy example that we use is the rotation that occurs at the elbow joint. The axis of rotation occurs through the humeral head, or excuse me, the distal humerus, and the ulna and radius moving. Rotate. I'm not really quite sure where the axis of rotation is on this big beast, but there's another example of rotation about an axis. So I can't define where the axis of rotation would be for him. Probably mid-spine. Kinematics. We will refer quite frequently in this class osteokinematics, which is basically the movement of bone. Osteo, bone, kinematics, movement. Okay? There are 3 planes of motion that we'll refer to, and we'll refer to this quite frequently. So if there's questions about our planes of motion or terminology, I want to help you through this. Okay. So 3 essential planes of motion that we'll refer to is sagittal plane, transverse plane, and the frontal plane. Okay. Sagittal plane motion will be occurring essentially in a flexion and extension or a dorsiflexion, plantar flexion direction. Sagittal plane motion of the shoulder is flexion and extension. Okay. Frontal plane motion is also called the coronal plane. Okay. So that is motion of abduction and adduction. Okay. It's something as simple as radial and ulnar deviation. Okay. So frontal plane motions. Transverse motion would be motion such as internal and external rotation in the shoulder, or upper trunk rotation on the lower trunk. So that is a horizontal plane, or transverse. So we can use that terminology interchangeably. Transverse plane or horizontal plane. Okay. Sagittal plane, frontal plane, or the coronal plane. And I'm not really concerned if you get the pronunciation correct, but understanding the osteokinematics and the 3 cardinal planes is important. So essentially, bones will rotate about a joint in its plane that is perpendicular to the axis of rotation. Those are a lot of fancy words. So essentially, flexion and extension of the arm occurring in the sagittal plane. The axis of rotation is perpendicular to that plane of motion. So the axis of rotation will run from medial to lateral. Okay. So that's where the pivot or the axis of rotation occurs for sagittal plane motion. If we look at vertical axis of motion, then we will be looking at horizontal or transverse plane motion. And if we look at the anterior-posterior axis of motion, so if our axis of rotation goes through the shoulder joint, then motion will be occurring in the frontal plane. Okay. So axis of rotation is where the joint moves from. Okay. And the plane of motion refers to basically the osteokinematic motion that's occurring. Okay. So flexion and extension, frame, sagittal plane. Axis of rotation, where the joint is rotating from, is the medial lateral axis. Okay. So this will be important when we start to talk a little bit more about arthrokinematics or joint motion, and then we apply specific mobilization techniques to help improve motion at the joint. So these are references. These are frames of reference for our conversations so that we can understand motion at a joint. Okay? And we'll revisit this even further. There is something referred to degrees of freedom. And we commonly ask how many degrees of freedom does that particular joint have? So if we're talking about the shoulder joint, the shoulder joint essentially has 3 degrees of freedom. And that's basically the number of movements allowed in the joint. So we have motion in the sagittal plane, we have motion in the frontal plane, and we have also motion in the transverse plane. So essentially we have 3 degrees of freedom. We also talk about osteokinematics in an open chain or a closed chain pattern. So an open chain pattern is simply the distal segment has an opportunity, and this might be reviewed for some. Our distal segment is open in its ability to move. So if I'm doing knee extension, flexion and extension, this would be referred to as an open chain motion. Closed chain is the distal segment now is fixed. So my foot is planted on the ground and I'm still doing flexion and extension of my knees. Okay. So essentially we have a proximal segment moving on a fixed distal segment for closed chain, and a distal segment moving freely on a fixed proximal segment for an open chain. So put that into perspective again. If we're open chain kinematics, my femur is fixed, my tibia is not fixed. So this is open chain. I have a distal segment moving on a fixed proximal segment. Okay. Go back to closed chain. I have a fixed distal segment moving on a moving proximal segment. This will also come into effect when we design rehabilitation programs for our patients, including athletes, which is a very hot topic of what type or mode of exercise is important to get people back to playing competitive sports or competitive play. So terminology, open and closed chain. Those are examples. Arthrokinematics is basically what occurs inside the joint to create motion. So this is specifically motion occurring between the 2 articulating surfaces. Arthro meaning joint. Okay. So again, we're using the example of the ulna of the distal humerus. And we will talk about 3 types of arthrokinematics were absolutely important to understand for treatment of human motion, the body. In arthrokinematics, we will see 3 types of motion that occur. We see a roll, a slide, and a spin. Okay. A roll is essentially multiple surfaces of one joint moving on multiple surfaces of another joint. Much like a tire rolling along the road. You have multiple surfaces of tire rolling on multiple surfaces of the road. For a joint, you would have multiple surfaces of one aspect of the joint moving on a different surface on the other articulating end of the joint. Okay. Okay. In a situation for the knee, let's go back to that. So if we look at the tibia moving on the femur, and if my roll is occurring posterior, there is portion of my tibia sliding on a different portion of my femur. Last year I broke him, so I will try not to do that. Let's see, I can show you. So a roll would be, there's a different aspect of my tibial plateau coming in contact with a different aspect or multiple portion of my femoral condyle. So essentially we're describing the roll, and we'll describe this type of motion as essentially as posterior rolling. Okay. We'll talk a little bit more about that, and we're going to get into something called a convex and concave roll, which we'll talk about. A slide occurs when you have one single portion or one single component coming into contact with multiple components of the other articulating joint. If my PIP was sliding on the palmar aspect, there's multiple points of contact on the palmar aspect of my hand, only one point of contact on the PIP. A simple example in human life is our slide. I have one point of contact, which would be my son's backside, sliding down the slide. Multiple points of contact on the slide, one point of contact on my son. Okay. So we'll talk a little bit more about sliding mechanics. A spin essentially is one point of contact on the proximal articulating joint and one point of contact on the distal articulating joint. So spinning will occur. Roll, slide, spin. These will become very important discussions as we go through this. There is a role, and it very much guides how we treat patients from a manual therapy or hands-on perspective of introducing care through our hands, but also care through our exercises and interventions. And it's called the convex and concave rule. And it basically describes the anatomy of the joint and how it moves on the other component. And if you have a concave surface moving on a convex, the roll and slide are in the same direction. So when we refer to the knee joint, we have a convex distal femur moving on a concave proximal tibia. So essentially the rolling motion, the tire moving along the surface, and the sliding motion are occurring in the same direction. They're occurring in the same direction to create knee extension. Bring back my friend. Okay. Whoa. I heard a crack. I hope that wasn't. So my roll of multiple surface of my proximal tibia coming into multiple surfaces of my femur at the condylar surface is occurring in the anterior direction. My slide, there's a translation, a sliding that's occurring with this motion, okay, is in that same direction. Okay. So essentially that motion is knee extension. Roll and slide the same. So if you have a concave moving on a convex surface, the roll and slide are in the same direction. If you have a convex surface moving on a concave, then they're in opposite directions. So prime example would be essentially your shoulder, would be an absolute excellent example of a convex surface moving on a concave. My roll is superior if you're doing abduction. My slide is inferior. If that did not occur, we would have about 60 degrees of shoulder motion. If there was not an opposite direction of the slide and the roll, we would be stuck here functionally. There is only so much joint surface that the roll can go onto, and once it gets to the top of that joint surface, it has nowhere else to go. And the only way it can improve is that you restore the sliding of that humeral head. And anybody that has treated conditions and I've watched individuals have severe limitations of motion, we need to look at the arthrokinematics, how that joint functions, and restore those biomechanical principles that make that joint function normal, based on our anatomy, how we were born. Now, sometimes our anatomy changes, whether it's through surgery or through arthritis, just deteriorating conditions. So sometimes these mechanics get altered, whether from surgical intervention or from injury or deteriorating conditions, so they can become changed. So convex and concave, we will refer to them as the convex and concave rules. We will refer to them quite frequently in class. And we'll go over them in lab again and apply the direct considerations. Okay? So our example here is our role in the abduction. So we're talking about the frontal plane motion or coronal plane, so abduction of the shoulder. We have a superior roll and an inferior slide or glide. Those two words will be interchanged. So the word slide or glide can be interchanged, at least in the U.S. We'll refer to those arthrokinematic motions. Okay. The second example was essentially if you had no inferior glide or slide of the humeral head, and you create a superior transitory motion creating shoulder impingement. Everybody good? Yes. So far? All right. Make sure you're still with me. Okay. Some other terminology, and this is just foundational things. We have to get through these next few days before we get into the good stuff. The good stuff is learning how to apply arthrokinematics to fix a hip, fix an elbow, fix a shoulder, help a back, get you moving, walking normally. So that's the fun stuff. We also talk about a joint having something considered as a closed pack or a loose pack position. And we'll refer to these positions basically referring to the congruency of the joint. So closed pack position, or CPP as we refer to it here, closed packed position, the articular surfaces are maximally congruent. They are as close as they can get to each other. And essentially all of our ligaments, or the majority or some degree of our ligaments and capsule, are tight. So the joint is at its closed pack position. There's very little joint play available in that joint. Are you familiar with the terminology joint play? Probably not. That's okay. Joint play refers to the extra motion that is available in a joint. It refers to, for instance, if I were to flex my elbow, go ahead, everybody flex your elbow, as far as you can go. So you can't go any further. Now, when you do that, take your other hand, put it on your wrist, and push it a little further. You have a little extra give in that motion. Motion that wasn't available through active motion alone. Joint play is that extra motion that's built into each joint. A joint in closed pack position will have very little joint play. The least amount of accessory motion, usually near the end range of your motion as well. The capsules and ligaments are tight. There's very little give to that joint. You've taken up what we call all the slack, all the extra mobility in the joint. It's really taken it to its end range. On the other hand, a loose pack position will essentially be any other position other than this it could be referred to. Now, there will be some terminology where people refer to the loose pack position where the greatest amount of accessory motion is available. In the shoulder joint, it is called the plane of scapula. It's approximately 30 degrees from 30 degrees abduction, 30 degrees into the sagittal plane. And it's an area where you have the most amount of play in the joint, where the capsule is lax, where the ligaments aren't engaged, where there's plenty of motion available. So these will also come into consideration of closed pack, maximal congruency, tight essentially, and loose pack. And there'll actually be some considerations when we get into techniques to help improve motion. Stiff joints. Because I'm in orthopedics, we see lots of different conditions. I see personally a lot of shoulder injuries, and I enjoy treating the shoulder quite a bit. It's a complex joint, 3 degrees of freedom, which we just talked about. Because of the complexity of the joint, it relies upon muscular stability and activation more than any other joint. There's no other joint that can do all this, right? My hip can't do that. I can't do all that motion. So there's tons of mobility in the shoulder joint. So we'll talk about stretching or mobilizing in a closed pack position, but we'll also talk about the benefits of doing it in a loose pack position as well. So those are some foundational terminology that we'll use for future discussions. Now we get into something called kinetics. And this is where we talk a little bit more about forces acting on the body. Kinematics is the study of motion without regard to force. For kinetics, now we talk about force and what's acting on the joint. Okay. So the forces can be internal or external. Internal will be produced from our own muscular activation and contractions. External can be something outside the body, holding an external weight, the force of gravity, all those things. Okay. The purpose of this course is not to do complex evaluations of understanding kinematic equations. We will talk briefly about them, but we'll use that application more so in treatment approaches for our patients. So we'll get into a little, in what I'll call fairly simple equations of understanding forces on the body and how to calculate forces. But this is not necessarily a course designed for research or laboratory investigations. This is an applicatory class, meaning what we want to be able to do is bring some light to this understanding so that we can use it in clinical practice to treat our patients, not for understanding a body of knowledge as far as research and taking very, very specific measurements. So we'll breeze. I don't want you to get overwhelmed or think about this excessively in terms of understanding the equations. It's appreciating the internal and external forces acting on the body and understanding with regards to torques acting on the body. Okay. The forces may cause translation or rotation. So an example, if our external force exceeds the internal force, there would be rotation occurring amongst that joint. And that's pretty easy to appreciate. We will also take into consideration the distance of that force acting from the axis of rotation. And we'll label those D1, D2, and distance 1, distance 2, just for the sake of labeling it. But they don't really mean anything other than we're taking into consideration the distance that external force is acting on the axis of rotation. So we'll briefly discuss that. And we'll discuss things called mechanical advantage as well, and we'll get into that as well. Our internal torque would be calculated from the attachment site of my biceps on my ulna. Okay. From the axis of rotation, so the distance from the axis of rotation, and the amount of force being produced from that joint. And that will be called torque. Torque is described in that manner. Our external force from the distance of axis of rotation is the external torque. Distance and the force. Okay. If my internal torque equals my external torque, I am producing an isometric contraction. There is no movement occurring. Okay. So isometric contraction would be essentially a muscle produces a pulling force while maintaining a constant length. No change in length of the muscle. Okay. Concentric produces a pulling force with a shortening. And then eccentric will produce a pulling force while the muscle elongates or lengthens. Pretty easy. We good on that? I think? Yeah? So we'll discuss, and I'm going to give you a break here in a second. We will talk about this again, foundational information, and we will build upon this and reinforce it through application. But certainly, these are some concepts that will be important. Let's take a few minutes of a break, of a recess. Get some water, use the restroom, do some stretching if you like. Move the arms around. And then we'll finish up with a few more slides and go through the rest. Okay. Now the one thing as well, if just to kind of explain as well, so I'm a busy guy, so I will have an obligation following this class that I have to be back into getting on the driving fast on the freeway to get back up to where I live. But if there are questions, you take this information and you're not really sure to make sense of it. We can use the start of every class as an opportunity to review and revisit and answer questions. And maybe as you read it again, you develop a further question. It may have sounded clear, but there's maybe a different question or spin-off. This class is about learning and essentially learning as much as you can to help patients. And I'm all about helping. So I want you to understand it, and if there's ever a question with regards to it, there is no problem at all. We will spend the time, and if you need some further assistance, I know Matt and I are happy to help you to get a better appreciation. So don't let all this terminology scare you, because there's real applications that will make sense when you think about the motion of the human body. That will start to like, oh yeah, okay, I can see that. Personally, I'm a visual learner. I'm a mechanical learner. I learn from doing, and I can visualize it. So I almost always, and I think that's probably obviously why I'm more into orthopedics. So this stuff excites me. I like it. But not all of us are designed the same way, and we don't have that same excitement with this type of information. So don't ever feel like, if you have questions, don't worry, we'll review, and there's no problem in reviewing. Okay. So take a few minutes, do some isometric and concentric exercises, and some eccentric if you like, or maybe just stretch your neck, and then we'll do about 5 minutes if you need it, and need a little break. Just a little water here real quick.
每天早上起来我就而且它那个弹簧很细，一分钟我一开始是做长假。
我介绍你学这个学的很多是吧？
我想是因为我们体会它跟那个按摩不一样，我们是做还有练功嘛。
对对有。
那都可以治什么啊？那主要在肚子下面啊。看过的。
内脏跟那个相似，但是
内脏松
就是两个学派打架，感情的交流。
两个人打不起来。要是有个3个人，一个派一个3、4个人，
对打起来，两个人打不起。
我只用这一个手法，那不是一样。
他只是举个电话。
你们的阵法是什么？来说给我，我们的阵法是这样。
我们也是，这个我练不出来，我只能是进行那么一小步。
右手，
可能是2、3秒。
左手就
没有右手好。
阵法应该主要是
就是感觉人阵无意冒犯，比较表面。没有渗下去。
你的阵法不能是要
我自己也不会阵法，是我们有个同学，他练阵法练的就是感觉超深层，震到深层。
就是他的那个震动的波长和频率非常的好。
对，然后就是他的波长很长。
我们的波可能就他的波是那种规则的波，然后我们就不规则的波。
我们是一个差别。我根本震不起来，除非是那种就是肌肉酸的不行那种，我不得不震的时候。
脑那叫抽搐，那个肌肉抽搐缺钙。
就是一会儿快，一会儿慢，他的老师3遍。哇，他讲的太上课这样好不容易，他现在高中一个新高中，我的大学小3是真的是这样的，小3是这个不是所以就讲不起来，更是说只有要玩。我不知道是不是这个。就是这个，就是要洗碗之前，
Yeah, I'll give it to you. Give the NDV support.
I get kind of bad at Milan. There's like a bunch of things and they put the number.
Yeah. Oh. All right. So, volunteer. Have a volunteer. Anybody want to be a volunteer? Go. Huh? All right. So hold the band. Okay. And turn and face your classmates. So right. Okay. Take a good step towards me first. Okay. So good. Stay right there. If you hold the band in this position, okay, hold it there. Don't let it move. Keep your arms still. Take a good 2 steps to your right. Step that way. What kind of contraction is that? Isometric. It should be if his arm didn't fall inward, right? Bring it back. Come back over here. Keep that arm still. Keep your shoulder blade, what we call set. Okay, keep that arm from moving. Same position. Yeah, right there. Step that way. Don't let that arm move. One more step. So he is producing a pulling or contracting force, but essentially maintaining the consistent or constant length of that arm. Correct? Yes. So he's an isometric. Agree? Yeah. Agree. Come back. So now pull away. Good. Right? Well, he's actually creating a, think about the muscles that are being used to create external rotation of his shoulder. So now we're looking a little more proximal. We're not necessarily dealing with a bicep or bicep forearm muscle. So we're talking about the infraspinatus teres minor muscle of our rotator cuff. So those are shortening contractions. So go ahead and demonstrate again. So this would be a concentric contraction, right? Good. Now step over that way. Good. So start out from here. Start with your arm all the way out. Yep. Good. Now let it just fall inward. Let it bring it in. Yep. Good. Now bring it back out again. Okay. Go back again. So that is an eccentric contraction. So if we think about our muscles that are producing external rotation of our shoulder, we're looking proximal into the shoulder joint. A few rotator cuff muscles, the infraspinatus, don't have a good picture, but I will, and the essentially muscles, thank you very much, thank you. And I have a pretty good 3D login, but I can't remember it. I'll see if I have it. Not going to get a good description here, but essentially when you feel it on your own shoulder, okay, if you put, or palpate, terminology I'll use is palpate, which is feeling with your fingertips, and you move in the horizontal or transverse plane in external rotation of your shoulder, you have a shortening contraction. You may feel the muscle kind of bulge or contract underneath your fingertips. Okay. That is called a concentric contraction. Real quick, see if I have. They've changed it, so I don't think I have my username saved. Okay, but essentially.
This audio is made with Audio Toolkit for Windows Store, downloaded for free now.